Hello, everyone. I guess we could start. We've got about two-thirds of the attendees online now. Welcome to CFN's webinar series. Today's webinar is going to be presented by Dr. Jacques Lee of Sunnybrook Research Institute. The title of his talk is Frailty Assessment of Older Canadians Using Emergency Services with Tablet Technology. Before we get into his talk, I want to just go through a few reminders. Just to remind everyone that there's going to be a question and answer session following Dr. Lee's presentation. Please submit your questions online during the presentation, and we'll answer as many questions as time permits. Before you log off at the end of the webinar, after the Q&A session, a survey will pop up on your screen. It's a very brief survey, and we really encourage you to fill the survey out because it provides us feedback with how to improve the webinar series, and we're really looking for feedback in terms of how to make the webinar more interactive and more enjoyable for our attendees. The webinar slides and video will be available for viewing online within 1 to 2 days, and that will be on our CFN website. Go to News and Events /webinars. As a reminder, we have a number of upcoming webinars that have already been scheduled. You'll see that there's 2 in February and 1 on March the 1st. These are knowledge synthesis CFN grants or studies. They've got some very interesting results, so we encourage you to register online and attend these webinars. Lastly, I want to remind everyone that our annual CFN Summer Student Awards program will be launching very soon. So visit our website at Summer Student Awards Program, and that information, guidance documents, and so forth should be online within the next few days. So without further delay, I want to present to you Dr. Jacques Lee, who will present the CFN webinar assessment of older Canadians using emergency service with tablet technology. Dr. Lee is an emergency services staff physician and scientist at Sunnybrook Research Institute in Toronto. He's the Director of Research for the Department of Emergency Services at the Sunnybrook Health Sciences Center. He's an assistant professor, clinical scientist, and former director of resident scholarly activities in the Department of Medicine at the University of Toronto. His research focuses on improving the care of older adults who need emergency services. With that, we'll transfer the webinar to Dr. Lee, who will begin his presentation. Jacques?
All right. Hello, everybody. Perry, can you hear me okay?
Yes.
You were getting a little robot-y Daft Punk there, so I apologize if I'm not coming in clearly. Sounds good? All right, I think this is a one-person talking at a time, so I'll take it over. Thank you, everybody who's in attendance. Good morning, afternoon, or evening, depending which time zone you're in. Very happy to see we had some international registrants. And I'm going to be talking to you about our CFN-funded project called FOCUS, for short, Frailty Assessment of Older Canadians Who Use Emergency Services. So, and I will gratefully acknowledge the financial support, which really helped us get this work on the ground, and I have no financial conflicts of interest to declare. I think it's worth pointing out what I'm going to be discussing with you is really groundbreaking research, so in the sense that we haven't even submitted this for peer review. So with that caveat, if I've got it wrong in my analysis, we'll be seeing it in the erratum of the publication. And really, you know, why am I here talking to you? What are my qualifications? You know, I'm an emergency physician. I have no formal geriatric training, but I know how to read, and I know where the library is. And in essence, I've been at least aware enough to understand that you need to get help. And so I've involved some really great colleagues. Dr. Mary Tierney is a neuropsychologist centered on aging study here, and she really helped us with some of the underlying neuropsychological aspects of measuring cognitive assessment in older people. Mark Chignell and Tiffany Tong Mark's a psychologist who works for the Faculty of Mechanical Industrial Engineering, which is very cool, focused on human factors and helped us design our tool. Judah Goldstein is a PhD paramedic, which is really super cool that we've got frontline pre-hospital workers who are now getting into academia, and a guy named Ken Rockwood, I hear he knows a bit about frailty, and my Quebec colleague,
when you sign your name, it shows your mic.
Marcel Lamond and Marie-Josée Sirois, David Ryan with the RGT, and our great will help from Alex Kiss, and Gary Nagley's been my mentor. He's a former Mary Trimmer Chair of Geriatrics. Okay, and nothing happens without Joanna Young, who's our national coordinator. Okay, so this you know, before I ask you to sit and listen to me for 40 minutes, I think it's fair to answer the question why. Why should we be looking at frailty in the emergency department? Why questions are. Oh, sorry, I don't know how that one got in there. The why of what we're doing this. If you see these two slides here, we've got the red line is Canadians under the age of 14 and under, and the blue line is Canadians 65 and older. And in June of 2015, those lines crossed, and they're going to continue on that same trajectory. That is, people who are 14 and under are going to stay relatively flat, while people 65 and older, thanks to the baby boomer generation and our amazing advances in health technology, are living longer, and they are going to double in the next 20 years. And Canada is the one country where the doubling of the older population will happen sooner than in any other G7 nation. So we are dealing with lots of older Canadians. The second thing is, right now in our emergency departments, if you've been to one lately, given our current resources, we are challenged facing overcrowding, and this raises grave concerns for the future. At Sunnybrook, for example, when I started in 2000 here, we were seeing 45,000 patients a year. It's now 60,000 a year. And just to give you a typical day, like 9 emerge docs and 30 nurses make 160 to 226 patient assessments per day, right? And 35 to 50 of those will be 65 plus. When you're dealing with a patient in the emergency department as a physician or a nurse or any clinician, the vast majority of times you've never met this patient before, so you have no familiarity, you don't know their history, and you're trying to figure out where they're at. So one little piece of the puzzle that we thought we could contribute to is developing rapid methods for assessing frailty for ED staff, and that's where the focus study comes in. So a few words on frailty, and remember, I'm an emerge doc who's read a little bit about frailty, so I am aware of the great debates about the definition of frailty, but I hope to take a more pragmatic approach. I think one thing that's important to remember is that the majority of older Canadians at any age, like, are robust, are not frail. So even those who are 85 plus, 56% of them are not frail, right? But there are a significant minority, and up to half of older people who have frailty, however you define it. And frailty makes them vulnerable, we know for sure, to many adverse events, which include falls, a functional decline. Functional decline is such a benign sounding word, but just take all the activities you need to do to get going in the morning. Waking up dry, getting out of bed, cleaning yourself, grooming yourself, brushing your teeth, get down and make breakfast, okay? So functional decline is pick one of those things that you would no longer like to be independent in doing, and that's what functional decline is. So it's really your independence, and that's very important to people. And another area that I've been focusing my research on is the topic of delirium. So delirium, or acute confusion, is a common event, maybe 10% of emergency departments. Delirium is independently lethal. That means that if you have 2 older people with urinary tract infection. One is delirious and the other is not delirious, and they're the same in every other way. The person with delirium will have double the risk of death. That's why I always say think of it as acute brain failure. It's an organ failure. And whenever we have organ failure, that worsens our mortality. And another common misconception is that delirium is just a reversible condition, like you're given a drug, you get confused, the drug wears off, and the delirium disappears. The problem is in people 65 and older, the average time to recover from a delirium after a hospitalization is 6 to 12 months. And if you're 85 years of age, you may not live to 86, especially if you've been hospitalized. So unfortunately, some people never return to baseline after an episode of delirium. So one of the things we deal with in the emergency department is we see an older person who's come in, they've had a fall, we deal with the consequence of that fall, maybe a laceration, maybe a sprain, maybe even a fracture, but we don't recognize that the person actually is delirious. In fact, studies from the 1990s showed that only about 25% of delirious patients were recognized by clinical staff. And we're sending home patients who are delirious, unfortunately, all the time. Why we miss delirium is a whole separate one-hour talk, but suffice to say that when patients who are discharged with delirium go home, their risk of death is 3 to 8.5 times higher. So that's very chilling. So, you know, as I mentioned, why do we miss delirium? Lots of reasons. I mean, the first thing is if we are not predisposed to check for delirium, so for example, if we assume that all older people have a bit of confusion and so we're not surprised when they seem confused, if we don't ask enough questions to really find out if they're confused or not, we're going to miss it. So another important fact about screening for older people is that while we have some pretty good clinical prediction rules in emergency medicine, the ones for older people don't perform nearly as well. They're not nearly as sensitive. So whereas for the Canadian ankle rules, which is helps tell if a patient clinically needs an x-ray or not, or the Canadian C-spine rules, which decides whether a patient who's had a fall needs an x-ray for their, those have sensitivities in the 99 to 100% range. And to date, the best screening tool in older people only achieves sort of a 70, 72% sensitivity. So we already know that there's a problem. One of the problems is that most emergency medicine screening tools use a small number of variables because that's all the time questions that staff have to ask these questions. So emergency staff are never going to be able to sit down and administer a 20-page questionnaire to a patient. But sometimes you need more than 3 or 4 variables in order to accurately identify people who are at higher risk. So we've got the problem that the minimum number of variables need to accurately identify high risk may exceed the maximum number of variables that staff are able or willing to collect. So our idea was that we should use tablet technology to involve the patient and family to collect a richer data set. Okay. So we also wanted to test this in a real-world implementation, and we focused on 2 things: frailty and one of its associated problems, delirium or dementia. We had a 3-province collaboration with Ontario, Quebec, and Nova Scotia. We were able to translate our tool, so we collected data in English in Ontario and Nova Scotia and in French in Quebec. I think it's important to say with the study of delirium, previous research by Adamus has shown that people who are most at risk to have delirium, so these are people who are feeling a little confused or starting to have trouble thinking clearly, these are patients are systematically excluded by the informed consent process. So you're in hospital, you're not feeling well, you're starting to, maybe you had a brief hallucination, and so you're starting to be troubled by your sanity, and then a research assistant comes up and asks you to read a 6-page form. We know from previous research that these patients are systematically screened out when we're doing studies on delirium. So rather than including patients who are delirious, sort of a yes/no, we used a tool developed by McCusker and validated called the Delirium Severity Index, which basically takes the typical delirium tool, the confusion assessment method, which is a yes or no answer, and then breaks it up into a 21-point scale with 3 points on 7 variables that are all part of the confusion assessment method. Okay, so so we wanted to use existing evidence-based questions plus some cognitive performance measures from what Tiffany and Mark Chignell describe as a serious game, right? So what we for frailty, we used the 1 to 9 point clinical frailty score published by Hogan and Rockwell, which just basically simply rates patients from 1 meaning very fit to 9 terminally ill. This has been previously validated in inpatient and community settings, but no studies have looked at the performance of this tool by patient self-assessment or caregiver assessment. They've really only focused on healthcare providers' assessments. And we use the pre-existing graphics. So patients, physicians, and the caregivers were able to look at this, and so they could say, I am very fit. I am as robust, energetic, and active as one can be at my age, do regular exercise, etc. I'm down to managing well. I have a few medical problems if they are well controlled. I get around the house and do my daily activities. So that goes on all the way down to people who are, 9 terminally ill and expected to die shortly. This is just sort of a screenshot of our serious game. So the idea was that patients had to hit the targets. We had raccoons and moles that they were supposed to hit. Sometimes there was a butterfly. They weren't supposed to hit the butterfly. So for each sort of level of the game, we got time and space data about the reaction time, how fast they hit the target, whether they accurately hit the target, and whether they hit the center of the target or how far off they were from hitting the target. We were able to enroll over 300 participants from Ontario, Quebec, and Nova Scotia. Their average age was 76 years, and they were just slightly under 50% female, which is a bit unusual. Most studies of older people are sort of 60-40 or 70-30 female, so I'm not sure why that is, and we're going to look at it if there was a lot of variation by center in our next analysis. So our first question is, can older people use the tablet data? And just to say, we obviously approached many patients to participate in the trial. Only 7% of all the patients who were participated were unable to use a tablet at all, either because of an injury, a previous stroke, or problem with their vision. Now that's the result of lots of preliminary data by our industrial design colleagues who had field tested the tablet many, many times. But yeah, only about 8% of potential emerge patients wouldn't be able to use this tablet. There were another 2% that we were excluding because they were in severe pain, and that was one of our exclusion criteria for the trial. So now, who participated in the trial? Of that 306, we assessed the Montreal Cognitive Assessment Scale, the MOCA, with 26 being the maximum score and sort of 24, 25, 6 being within the normal range. So there's some evidence that our population contained patients who had some mild cognitive impairment, and going down to 16, that would have been consistent with diagnosis of dementia. So there were some patients with dementia. Now, remembering our clinical frailty scale, the CFS, physicians rated this, and one low score means quite robust, and 9 is the highest possible. So the average score, as assessed by physicians, was 3.4. When patients self-rated, their average was a little bit better than the physicians. They rated themselves as a 3. And we excluded patients who were in severe pain, although there were some patients who had an element of pain. So, like I said, with our 306 participants, they could collect 5 or 6 data points from up to 200 interactions with the tablet. So in total, we collected over 3,000 data points on 306 participants, or 900,000 data points. So yeah, we've got a lot of work to do to get this all analyzed. So the first thing is what happened to our cohort. Like we said, we were able to get follow-up out to 3 months on a total of 306 participants. We had about 3% of the population had a subsequent 911 call. About 10% returned to the emergency department. 2 to 3% were admitted, and 3 to 4% had died by 3 months of age. So we summed all of these outcomes into either health needs or adverse outcomes as a composite, and about 14% of our population had a health need or an adverse outcome by 1 month, and that was up to 17.5% at 3 months. Okay, so the first question we had was, does the clinical frailty scale predict health needs? And the second question we wanted to know was, did it matter if the data on the CFS was collected by the physician? We used the research assistant as a bit of a proxy, you know, as a non-professional. These were all mostly BSc students who had been trained for the study, as well as we looked at the patient and the caregiver. So we had sort of 4 CFS assessments on all our patients. And indeed, if we look at a cutoff of greater than or equal to 3 as indication of some frailty, the MDs did pretty well. They identified 80% of patients who had an adverse outcome at 1 month, and 77% of patients who had an adverse outcome by 3 months. And these 3 findings were statistically significant. As we looked at the caregivers were, although it was a very small sample size, they were not as good at identifying adverse outcomes, and patients also, their identification, their self-related clinical frailty scale did not achieve statistical significance. Okay, so then what about our serious game? As we said at the beginning of the study, only 3 of the patients we enrolled met our definition of delirium for a rate of 3 out of 306, which is 1%. And this is well below what we would expect based on prevalence studies in the ED, where prevalence of delirium is 10%. So we've kind of reconfirmed that using an informed consent model and approaching patients to participate in the research produces a selection bias, meaning it's hard for people who are delirious or on the borderline to get into the study. But we did identify 24 out of the 306 who didn't necessarily meet a strict criteria for delirium, but had a delirium severity score of 4 or greater. So we're going to use that as a bit of a proxy measure to help us look at the patients who are at greatest risk for delirium in our population. And that leads us to our second question. Did our serious game predict delirium severity? And yes, it did, in the sense that the mean score for patients who had a delirium index was much higher, was higher amongst patients who had a high delirium severity index compared to patients who had lowered delirium severity index. So, in conclusion, our focus tablet data, first of all, we proved it was feasible to collect in the emergency department, and we did have some pre-hospital data, which I haven't showed. We showed feasibility using it in 3 different healthcare settings and in 2 languages. So, and we did show that patients were willing and able to participate, at least in a research study. We validated that the clinical frailty setting in the ED, as assessed by physicians anyway, is a valid tool to help predict adverse outcomes. I think it's possible that patients and caregivers are also able to predict adverse outcomes, but that our study may have been underpowered to detect that. So that needs to be detected, assessed in further research. We also validated that the use of our serious game to identify patients at risk for delirium was able to sort of, again, with a fairly small sample size of patients who were at risk for delirium, but we were able to identify it using a composite measure of their test performance. And we also established the feasibility using our tablets to automatically refer patients. So if, let's say, in the future, the way we envision this going, we identify a patient as either having high frailty or higher delirium severity risk based on their serious game performance. We can automatically send an email notification or a message notification to either a geriatric emergency outreach nurse or the charge nurse or different types of professionals depending on the setting to alert them that this patient is at potential risk for having adverse outcomes or having full-blown delirium. All right. So that leads us to our next step. Our next steps are to validate these findings in a larger sample so that we can get a better handle on whether, for example, the patient and caregivers actually do predict adverse outcome, but it was just our study was underpowered to find them, to validate our findings, and to develop more precise cutoff scores with our serious game so that we can assign a risk for frank delirium. We're also currently conducting research. This research I described to you was based on a single assessment of a patient in the emergency department. We are now doing studies where we follow patients with the tablet through their whole emergency stay and hospitalization, up to 72 hours after the emergency stay, to see if the tablet can help us predict the trajectory of patients who are not only discharged home but admitted to the hospital. And of course, the ultimate goal of all of this work is then to use this to help us identify high-risk patients and then test a preventative intervention to help us prevent delirium and prevent, maybe head off the path of the unmet health needs or adverse outcomes in this patient population. So I have a tendency of going long. I made a real effort to keep the number of slides low, and I talked rather fast, as I'm tend to do, especially when I can't hear any feedback from the audience. So I thank you very much for your attention. That's my email. If you have any questions about our research or you're interested in collaborating, love to hear from you. Stay calm and focus on. Perry, I'll turn it back over to you. Thank you very much.
Great. Thanks, Jacques. Excellent talk and very interesting results. Look forward to the follow-on studies. Just to remind our audience that you can ask questions on the side window there if you'd like. We've got some questions in right now, Jacques, so I'll start off with those. Just maybe a procedural question in terms of the emergency department or the emergency room. Currently, is there a checklist or any sort of assessment that's done related to these sorts of things in terms of delirium, frailty, and so forth, sort of, if not on a formal basis, do you and your colleagues sort of look at this during your practice?
So I can say there's attention to it. There are best practices, and like so many things in all areas of clinical medicine, there's huge variability. I can say that with some certainty. So, for example, Perry, that raises an excellent point. Trauma care has become highly protocolized, and the trauma care we give at Sunnybrook, by the trauma team, compared to, Labrador and Northern Saskatchewan, will probably be a lot more homogeneous and similar than geriatric care. So the best practices in trauma, kind of a peri-military hierarchical structured approach with checklists and formal procedures. We haven't got to the point of doing that in the emergency. We've done research at Sunnybrook and some quality improvement on a program called Interprofessional Prevention of Delirium, which is sort of a way of introducing some structure to the care, and it's totally borrowed from Sharon Inouye's work with inpatients called the HELP program. But we've designed a kind of a protocolized approach that uses volunteers to help prevent delirium. But I can't. It's being, like 5 or 6 different hospitals have talked to me about it. But I think in every hospital in Canada, pretty much, if they do pay attention to elder care, most of the time they sort of develop their own protocol and initiate it. So while my colleague Don Milady in his excellent website, Jerry EM, has some educational resources, I can't say with any knowledge that this is standardized across Canada.
Right. Thank you, Chuck. With respect to the sensitivity issue, we have a question with respect to what is the harm if the sensitivity is, I believe what you said was about 70% or so, in misdiagnosing patients as frail. Other than, of course, the stigma, would there be necessarily harm done in that scenario?
Yeah, that's a great point. With CT scan type rules, the costs are radiation and actual costs, right? The problem, I think, is that if you look at geriatric research at all of the interventions, so the most sensitive tool of all is if you're 65, just assume that you're frail and kind of treat everybody, right? So that way you would achieve 100% sensitivity, okay? And the problem is when we look at the geriatric research that when you kind of adopt that broad spectrum approach, treating all older people as vulnerable or frail, we haven't seen that those interventions are effective, okay? And I think it just speaks to whether you believe into the concept of frailty or not as a kind of a state of vulnerability that only some older people have, right? So I think there is a problem, there's a labeling problem, okay? So, like I've got my 82-year-old who is training for a century ride and slipped on some leaves, and he came in with a broken collarbone, right? And versus a patient with dementia who is supposed to be using a walker but forgets and falls outside on their front porch. Like, those are two very different people, and I think there is a problem with treating them the same. The second thing is most services are highly limited in the number of resources they could provide. So while that may not necessarily be a sensitivity problem, I think we want to try and develop specific tools in older people that will allow us to prioritize those older people who need the resources first. So there's a 6-month waiting list for our local falls prevention program. So if we mindlessly referred every older person who came to the emergency department to our falls prevention program, that waiting list would balloon to 5 years. So we do have to, you know, of course the solution is always more resources. I don't work on that end of the spectrum very much. I leave that to others, you know, but given the resources that there are, I think there's some value in trying to identify people who are most likely to benefit. But that's a great question.
Right, excellent. Thank you, Jacques. We have a question here, a comment first. Great work, Jacques. Wondering if you track the time to complete the tablet self-assessment, including perhaps setup time, completion, and any feedback.
Right. So there's two separate parts to this. We were doing objective research-based measurements as our gold standard, right? So we administered the CAM. I mean, the thing that took the longest is the MOCA, right? But we also did, I think, the SOFA and other quality of life and activities of daily living, ADL. So that whole thing, you know, could take up to 45 minutes. The clinical frailty scale takes about 10 seconds, and the serious game, people can, you know, kind of the way its current version is they would max out at about, you know, 2 minutes of gameplay that you know, they've sort of hit the maximum level we've developed. And I mean, one of our concepts with this is that eventually what we're going to get to the point where this would be a free range thing, that we would give it to an older person when they came in. They might do some baseline assessments in the waiting room on a fixed, you know, we have a kiosk now where they sign in, you know, while they're waiting to be triaged even, and we could get some baseline data, and then we would track their performance during their ED stay. But why in the heck would, you know, if we don't have a paid researcher in every emergency department in Canada, why would anybody use the tablet? Well, we're incorporating entertainment aspects to the tablet so that people will want to use it, you know, and the cost of using it will be, oh, you've got to do your assessment, right, you know, so that we'll get patients to continue doing the testing, and then we know what test performance is. So the long-winded answer to their question was, how long does it take? The actual game part, you know, takes, you know, like less than 3 minutes, and it's meant to be done on a repeated basis. The whole research participation was about 45 minutes.
Okay, great. So, Jacques, is there any value in this test being done at home by the patient or by the citizen in a sort of a periodic basis, or is that left better in terms of being done at the clinical site?
I don't think our data speaks much to community-based, because it's a very different patient population, except as a proof of concept. Dr. Tierney is actually one of my colleagues is one of the leaders in doing more formal cognitive testing at home, right? And absolutely, the concepts could apply. The idea of delirium in the community is a little bit less of an issue. So what would be better would be to test people's cognitive function for the more chronic form of cognitive dysfunction, that is dementia. They actually have done studies where they did random telephone assessments of patients in the community, and they thought maybe 1% of the population might be delirious out there in the community, right? But again, I'm not sure that delirium assessment in the community necessarily would be the way to go. It might be really useful in a nursing home setting or a assisted living setting where you have a higher concentration of people at risks. And one of our one of this project was designed for is for use by community paramedicine programs for people who aren't familiar, particularly in more rural settings. My colleague Mike Nolan is an international leader on this. When paramedics are sitting around waiting for calls, they actually go out and do wellness visits on older patients in their community, because they've got they know there's a 85-year-old widower who lives on a farm that's remote and inaccessible, and they might be the only people to check on that guy, once a week. So that's a setting where we are specifically targeting for this type of testing.
That's great. We have a question here, comment first. Thanks so much for a great presentation. I'm wondering what your impressions are with regard to patients and caregivers' poor accuracy in their CFS values to predict adverse outcomes. Is this information worth getting from patients and caregivers?
Well, I think, this is a small sample size. We had 300 patients, which was, given the time frame we were given, we're proud of, right? But I think there's some potential value. The caregiver one, I'm going to say, is, let's just look at it as purely a sample size issue. That we really had, we had a total of 32 caregiver assessments in this current study. So I don't think we can actually speak to how accurate the caregivers are. The fact that the patient's self-assessment, I think there's things to learn from them. One, the patients were consistently and systematically assessing themselves as more fit than physicians. So I don't think that that's who's right, who's wrong. I think that that's information. I think that that we sometimes end up in a bit of a adversarial or conflicted position with older patients. Older patients may be worried about losing independence, may be worried about being interfered with, may be worried about losing freedom. So if there is a tendency to assess themselves as less, as more robust, less frail than their kind of health needs might predict, then I think that's something we need to work on, if this is borne out to be true, and say, first of all, are you just saying that because of fear of reprisals if you give accurate information? So that, I think, is a really rich area of research, and that's certainly my impression over the years, that I've got many patients who kind of tend to lowball things because they're afraid about losing their independence. And if we start from a shared goals view of, look, I don't want you to be anywhere that you don't want to be. I just want to figure out a way of keeping you in your preferred environment as long as possible.
Interesting. Is that message relayed to the patient during the study in terms of?
No,
sorry, go on.
Yeah, not at this point yet, because this is fresh off the press. I need to do further exploration, get it before peer review, and I think that would be part of the next thing, right? Whether looking at two average results, from 300 assessments is very different from looking at individual patient assessments. It's a really interesting idea. Thank you, Barry. But it needs to be tested separately, right? When you're talking about individual level patient decisions, then you have to really rigorously test that and not base it on mean differences between populations.
Right. Okay. So a couple of procedural questions. One's a practical question. How did you keep the tablets from disappearing during the study?
Right. So the first thing is we chose tablets that were less attractive. So we didn't use any eye products. Okay. We used relatively inexpensive Google products, and this question's come up over and over again. In our setting, they were kind of supervised by the research assistant. Yes, absolutely, there's the risk that these will go missing. A bit my goal is we've tried to keep nothing we did is really very high tech or requires high-end technology. So eventually, I can see a future where we're moving towards the smart paper. So you've got a tablet that's so cost-effective it's almost disposable, and hopefully the crappy one that we use in the emergency department would be less attractive than the ones people already own. We've explored sort of RFID and other kind of security methods, like locking it up if it like conceptually, like the tablet locks up if it leaves the parameters like shopping carts. But you know, hey, I think we still have to prove that this technology is useful before we worry too much about people stealing it.
Right. Okay. Another sample size question, if you will. How many people were invited in order to get 306 patients? How many were physically able to do the test but were unwilling to participate, i.e. declined to participate?
Got it. So sorry, don't have that number in front of me, but you know, it's about two to one typically. There were probably about, like, if the number I gave you, about 7%, 8% who were unable, and probably 3 times that many refused of people we approached, right? So we did not include patients who had frank dementia and who weren't capable of providing consent. That means they weren't able to understand that we were conducting research. They weren't able to understand that we needed their consent. And so that was the #1 cause for exclusion. So that was like 30%. There were another group of patients who were critically ill or in severe pain we didn't enroll. And then about 1 in 5 to 1 in 4 patients refused to participate because it was too bothersome. You know, they didn't feel like it. And that's a fair criticism. When people are sick, they may not want to participate, you know, but we were sort of glad to see that physically being unable to use the tablet was only about 7 or 8% of the population.
Yeah, that's great. Certainly would be on low on my list if I were in the emergency department.
Right, but let's say, what if you could, you know, check the stock market, or get access to other information while you were waiting, right? That might change the parameter, and that's really our goal, is to sort of create focus like a Trojan horse in a whole package.
Oh, I see. Okay. We had a few questions sort of in this sort of line of questioning. So I'll ask this one. Will you examine whether the serious game can predict delirium more than if you asked a few more questions to identify high-risk patients?
The few more questions was our gold standard, if you know what I'm saying. So the delirium severity index is it's not even, it's a clinician assesses a patient on 7 parameters and assigns a 0 to 3 score. Okay, so you know, and I often get this, why don't you fill out a simple form? Why don't you do this, do that? Like, there are lots of, so I've been doing emergency medicine for 25 years now. There's lots of, and one of my roles is to protect my colleagues from unnecessarily complicated research, right? So, because everybody wants to do research, and they say, oh, well, just, it's just a two-page form, right? So I'm just going to say that, like, until you live it, it's really, really hard to explain to other people how difficult it is to add on and change workflow for something outside of. So the concept of, do I have proof? No. But am I going to do research in that area? I'm going to leave that to others, because I think it's going to fail. My real feeling is that we've got to find, it's always easy to say, work harder, do more, come on, it's for the patient, right? And I don't think anybody gets into healthcare or emergency medicine in order to do badly by patients. But, unless you're living the daily grind and know what it's like, it's just a little too easy to say, let's fill out some more forms, right? I think it's completely possible that the tablet and standardized questionnaire would be equivalent. In fact, like I said, we use the standardized questionnaire as the gold standard, right? So in a sense, I know that answer. Yes, you could. Yes, it's theoretically possible that everybody could just have delirium indexes, and that that would be a good predictor. But do I feel very excited about trying to get people to do that? No.
Right. Yeah, we're certainly I don't have first-hand experience with that, but we're seeing a lot of we're funding a lot of studies looking at feasibility of, as you say, changing workflow and so forth, and the difficulties with respect to that. So it seems to be something that many of your colleagues agree with. Maybe we'll. I notice we're coming up to the top of the hour, so I'll ask one last question. And that's, I agree that informed consent has limited the evidence base in geriatric emergency management. Often we can't study those who we intend to identify and care for. What's your outlook or opinion on informed consent requirements in ED research?
Yeah, so I mean, first of all, I have to say, yeah, we absolutely need to, adhere to, the Tri-Council. Like I don't ever see ethics as a barrier, or it's, getting in, because people absolutely have the right to have their independence and autonomy protected. Now, as a member of our local REB, though, I think there are possibilities to design what we call minimal risk studies, where we would look at more of a model of patient assent. So an example of this is, for many legal reasons, consent forms have inviolable sections, that they have language that's determined by laws that need to be included in a consent form. And it's really difficult to get a consent form that's less than 6 pages, right? Like once you've put in all of the legal requirements, the document, usually ends up, sometimes it's 4, but 4 to 6 pages is about the bare minimum, especially when you consider that we've got to have large size print, So the problem is that the consent process can often be more onerous for the patient than the actual research could be. And I think the going forward is to try and come up with models where we might look at minimal risk studies, meaning there's truly no risk to loss of patient confidentiality. There's no risk to the patient because it's not an interventional type of study, and that we can work with a well-designed assent model. We want to ask you a couple of questions. You can quit at any time, this is what's involved, right, and I think that that's an area that requires careful study, and it has to always be subservient to the local REB, meaning, you have to work with your REB, explain why you think this patient population is being underserved by current research practices, how you think you could design a study that will respect their autonomy, protect their privacy, but not systematically exclude those most at risk. So it's not easy. It must never be shirked, but I think we need to be creative, and I think REBs have to also participate in that, keeping in mind all of the fundamental principles, right? That if you're requiring a consent form that's 25 pages as a minimum for every possible type of study, then that probably isn't in patients' best interest.
Right. Couldn't agree more, Jacques. We're seeing a lot of REB delays as well, and maybe some common sense might be needed, but we'll leave that for another day. I want to thank you for spending a bit of time with us. It was an excellent talk and excellent Q&A, Jacques, so thank you very much. And I want to thank the attendees for listening today. I just want to remind everyone that, again, the Summer Studentship Awards program is being launched in the next few days, so please visit our website and register for upcoming webinars that are listed on the online right now. Again, thank you, Jacques, and talk to everyone soon.
Thanks for the opportunity.
Okay, bye-bye.